Welcome everybody. It's Tuesday afternoon in Houston, 5 p.m. We're coming to you live from Methodist Hospital, the Bakey CV Live at Texas Medical Center in Houston, Texas. And we're very fortunate to have Sandy Schremeyer on with us for this hour. She has an incredible amount of experience in AFib, both personally and also as the administrator of the website Live AFib Free. We changed the format last month and we added an option for people who viewed the webcast after it was live, and that option was to submit questions that I said I would address those questions at the following webcast, which is today. So here we are, Tuesday, 5 p.m., first Tuesday of the month, although I think we changed it this time, but usually it's the first Tuesday of the month. So we will start out with some questions after I introduce Sandy. Sandy, thanks so much for joining us. Welcome to the webcast. You know this routine. You've been on here a few times, and you also have your finger on the hopefully regular pulse of people who've had AFib and who are now on the website. And some of the questions that came in are probably more appropriate for you to answer than me. But Sandy, if you want to give a short synopsis of who you are, and you were in the medical field as an RN, and what you went through and how it came to pass that you became the administrator of a Facebook site that deals with AFib.
I had 3 failed ablations, and I was offered as the last resort an AV node ablation, a pacemaker, and a Watchman, all of which were a hard no for me. I did my own research. I found you. I had the Wolf procedure 7 years ago now, and I am doing great. And as far as the Facebook site, it was laying dormant for years. Actually, I believe your daughter started it when she was in college.
Yep.
And I joined it, and there was 9 people. And the administrator who was there actually didn't even know how he got to be the administrator and asked me if I would help him. And I said, sure. And then he said, well, you seem to have a lot more knowledge than I do. And he turned it over to me. So here I am. That was maybe 4.5 years ago now. We started out with 9 people. We now have close to 4,000.
That's amazing, and it's all thanks to you. A lot of hard work behind the scenes, and a lot of people depend on you to help them with their journey through AFib. And I think what makes it particularly helpful for them is you also were in the medical field for many years, right?
Yep, for sure.
You were a registered nurse and clinical, right?
Yes, yes.
Yeah. I did mention to Sandy, I wanted to mention to everybody, one of the issues we had is we were a little bit too popular, and we had a backlog of patients to take care of, and that backlog kept growing each month, which bothered me a lot. I think it bothered Sandy. So over the last 4 or 5 months, our team has been very diligent. We've been able to whittle that down, take care of the backlog through several different things, such as one of the points was that patients were seeing a nurse practitioner first, and then they were seeing me. And for half those patients, we just cut that out so I could see them more quickly. We were able to be a little more efficient in the operating room, get more cases done. And I'm really happy to announce now that Kimberly Martinez, my nurse, has said that the wait time once someone sees us is now down to about a month. So around 30 days. So this is a huge change from what we've had 6 months ago when I was seeing patients that had seen me virtually a year before. So we're back down to where I like it. It's more comfortable. It's better for the patients. It's better for everybody with about a month wait time. So that's the big news. Now,
That's incredible.
that's a big change, but thanks to the OR team and Kimberly and Christina and everybody who helped make that more manageable. Question for you. There are several questions here. I'm looking at them on the screen. Sandy, the question is, and again, these questions came in after the last webcast, so these are people that viewed it after it was live. And by the way, before I take the first question, we should let people know how they can ask their questions live. I still prefer the live questions because you and I can interact and take care of it on a real-time basis. So, Mr. Producer, let's put up there what they have to do. If you're joining us now and you have your phone, you go to 37607 and text DeBakey, and you can ask a question. If you're on your computer, go to pollev, that's pollev.com, enter DeBakey, and then ask your question. And we'll show that a few times, but the key is don't wait till the end of the hour to pose your question. It's much better to throw it up there now, and hopefully then we'll be able to get to it. So one of the questions was, what's the recovery process like after the Wolf procedure? Sandy, you went through it, so you can give your experience, which isn't the same as everybody, but it's the N of one.
It isn't. I actually had a pretty decent time. I have trouble with anesthesia, so the whole first day I slept. So maybe when I woke up, I was feeling better, but I didn't have a shoulder pain that a lot of people will feel, or some discomfort during the night that most people will feel. I took nothing but ibuprofen. They got me up walking the next day, and once the tubes are out, it's a whole different ball game. I remember telling my nurse that I just want to sit up. I've been laying here for so long. And she said, okay. Well, she went to help me sit up, and it's like, oh, okay, what is that? And she said, oh, it's the tubes rubbing. I said, okay, I'm just going to lay down until we get these out. But once the tubes are out, it's a whole different ball game. I did stay another night in the hospital because my blood pressure was really low, which is typical for me anyway. And then I went back to the hotel for 5 days and recovered and had my link put in and went home.
Okay. Dr. Wolf, are there any cases known to you that AFib came back after your procedure? My electrophysiologist said it can happen and there's not really a cure for it. Well, the first part of the answer is no procedure is 100% effective. I do feel that what we do with the Wolf procedure is 100% better than a catheter ablation as far as AFib free, and also after this procedure, patients don't have to take a blood thinner because we close the left atrial appendage. But it's never 100%. The most common scenario is someone who's had multiple previous ablations and after this procedure may still have some atrial flutter, which may burn itself out, but it may not. And if it does not, we've been very successful at going back with a catheter, yes, another catheter ablation, but specifically looking for sites that were outside the area of the Wolf procedure. So the Wolf procedure focuses on the nerves on the outside of the heart. I believe strongly that's where AFib starts. That's where it is initiated. And getting these areas is the key, but there still is a place, even after this procedure, for a catheter ablation, almost always for flutter. And Sandy, you had 3 previous catheter ablations, and you had that for a while, right?
I did. I came home and I had relentless flutter. It came and went, but I did have a cardioversion at about 4.5 weeks, but it hung around, and I really thought I was going to need that catheter ablation. But I still wanted to give my heart that whole year to heal because I had been gone. I had been through so much. And the last episode was actually the longest episode, and it burned itself out after that. I've never had it again.
Yeah, and that's not unusual. But yes, and it's usually not AFib coming back. It's usually flutter, and it's usually some area outside of where we worked. Now, we've also seen people that have had the procedure and they're AFib free, and something sets them off and they get flutter again or fib. And we saw this particularly during COVID. I had one patient who was 14 years out, no AFib at all. He got COVID, and within a week he was out of rhythm. Now, the good news is with cardioversion, that usually takes care of it. Occasionally, an ablation might be needed, usually successful. But a lot of times, just a cardioversion to get back in rhythm takes care of it because it's an acute event. And once the patient's over that acute event, things settle back down to normal. But there's a lot of information, a lot of articles that suggest that COVID causes a myocarditis. Itis means inflammation. Myocardial is heart. So there's a lot of information suggesting that this particular nasty virus causes a lot of heart inflammation, which can lead to arrhythmias. But once that's settled down, then things should clear up. Let's see. See what else is here. How does the ligament of Marshall affect AFib, and what is done with it in the procedure? A little bit of an anatomy lesson. I should have Dr. Miranda here to give this, but I'll fill in for him. Before we're born, we have two main veins that drain into the heart. One from the right side of the body, upper body, the neck and the arm, and one from the left side. But before we're born, that main vein on the left side closes down completely, normally. And all the blood goes across under the sternum to the right side, and almost all the blood from the upper extremities and the head drains into the heart from the right side. In some patients, that left-sided vein doesn't close off, and it's called a persistent left superior vena cava, so you still get drainage. But in most of us, when that vein on the left side closes down, it still has nerves on it. These nerves, these thousands of nerves that come to the heart, come around the pulmonary veins and the pulmonary arteries and the superior vena cava. So that vena cava on the left shuts down before you're born, but the nerves are still there. That's the ligament of Marshall. That vein becomes a ligament, and it has nerves in it, and some of those nerves can be active. They're autonomic nerves. They can be active in AFib. So I think it's important to divide that structure, that ligament, and it takes about, 5 or 10 seconds to divide that ligament of Marshall. But I think that's important and part of the partial denervation of the heart to cure AFib. What can cause less than normal breathing performance after the Wolf procedure? Well, initially, as Sandy mentioned, it's the chest tubes. There's a tube on each side. Just to be conservative, leave a drainage tube on each side. We usually take it out the next morning. And after that, there's still some discomfort from the adjustment of opening the heart sac, and that takes a while. We do close the heart sac back up. That's a common question. We do suture the heart sac back together, but it's still been manipulated, and there's still some inflammation there. Anytime a procedure is done on the heart, we have to open the heart sac, and that causes some inflammation. And I think that's related to some of a little bit of, it's hard to take a real deep breath for a while. Although you didn't have too much of that, did you, Sandy?
I didn't.
Yeah.
Like I said, just once they were out, I was fine.
Yeah.
It was just moving when they were in.
Okay, why is walking important after the Wolf procedure? What would be the consequence of too little or too much walking during recovery? Well, I don't think you can walk too much. I do tell patients, I suggest to patients, I don't tell them, I suggest that several short walks are better than one long walk. But you can't tear anything loose, and you should walk as much as you're comfortable walking. Why is it important? Well, the number one complication after any general anesthetic, whether it's orthopedic surgery or heart surgery like I do, or general surgery, are blood clots in the legs. That's number one. So we know that by walking, you squeeze these muscles in your legs, and that returns the blood through the veins back to your heart, and you don't have what we call stasis, or places where the blood pools. So I think the most important part of walking is to move the muscles of your legs so you don't get a blood clot in your leg. Now, it also helps, it's known from several studies, that if you are in bed for a week, it takes about 6 weeks to get back to baseline. So the faster you can get up and move around after having surgery, after being in bed, the better. And it makes a huge difference. And I'm sure that's been your experience too, Sandy.
Yes.
From a clinical standpoint, ambulation is so important.
And just the chance of pneumonia too. You want to keep moving.
That's true too. And it changes the position of the lungs. It turns out the worst position for your lungs is lying on your back, which is what position most patients are placed in the hospital. We learned from COVID, the first thing to do with COVID patients is turn them prone, right? Mm-hmm. And that saved lives.
It did.
So dependent position of the lungs, lying on your back, is not good. You're absolutely right. So I think with that, we should, let's see. See if there's anything else here we need to get to. I think that's enough there. And I think what I'd like to do, again, let's show the way to join us if you have a question, either by text or by web. On the right-hand side, you can see joining by text, 37607, text to Bakey. The question can be for me or it can be for Sandy. Or if you're on the computer, go to pollev.com, enter DeBakey, and give us your question. So I guess, Mr. Producers, we'll kind of switch to new questions after we talk to Sandy a little bit here. Before I do that, I did want to show the video. It's a short video. I showed it, I think, the last webcast, but I think it illustrates what we're talking about how I feel AFib is initiated and maintained, which is different than conventional wisdom. Mr. Producer, do we have the video that we could show? And it does have audio.
An important component of the intrinsic cardiac autonomic nervous system consists of ganglia are located superficially, and they interconnect with deep GPs, cardium. 12 GPs around the right and left pulmonary veins achieves partial isolation and inhibits transmission to heart, resolving symptoms as opposed to endocardial catheter ablation, which does not target nor.
The video, these autonomic nerves that are, and our goal is to the number of these nerves in left atrium. We don't eliminate them. We decrease the number. It's a partial, and that seems to be enough. The autonomic nerves back and prevent the AFib. We don't bring up the heart's the answer. On the inside of the heart, freezing procedure. I don't think that's really the answer. I think you got to get to on the epicardial or area of the heart, which is where we concentrate our activity. Sandy, there are always questions that you have a handle on that come up repeatedly, and I'm sure you get tired of answering them, so maybe we can help you a little bit decrease the number of queries you get for the same question.
You kind of answered one. Somebody wanted to know if you had to have a catheter ablation after, just really what did they ablate as you're trying to not burn the inside of the heart. That's why we had the Wolf procedure in the first place. But you did kind of to be in persistent AFib or flutter to have a cardioversion. You can't do it if you're paroxysmal, correct?
Okay, correct. The only when the heart is continuously out of rhythm do we recommend a cardioversion. Intermittently, not recommended. Amazon Prime for, I think, what, $70 or $80?
Yeah, the question is a 6 lead okay? The
Oh,
small, or the earlier
I
one, or
think,
a 12 lead?
no,
It's hard, it's,
I think the cheapest one's the best.
it's, okay, thank you. Because I believe that as well. But
Because I think it's based on the fact that we're not looking to see if someone's having cardiac ischemia or rhythm.
you want to
So
see the
for the
rhythm.
rhythm, the least expensive one is fine. And keep in mind, everybody, these devices are great, but they're not that specific. They usually can't tell the difference between atrial fibrillation versus atrial flutter. I think what you can say is if it says you're normal, it's probably normal. Not always, because sometimes you can have a slow flutter and it looks like a normal sinus rhythm. But in general, if the cardio or even the Apple Watch says it's normal, it's probably normal. If it says it's abnormal, it may be abnormal, it may not be, and it's hard to tell what abnormality it is. I like the Cardia because it has the option to send a copy of the tracing by email. So it's very easy, it's convenient to send it to a physician or our office by email. So I'm fine with Cardia. And the Apple Watch is okay, but as you know, it's got what we call false positives. It may say the heart's out of rhythm when in fact we can't find that it is.
Okay.
I think the advantage of the Link device, the implantable monitor, is one, you don't have to pay any attention to it. Two, it works 24 hours a day. If there's an abnormality that mainly occurs while the patient's sleeping, it will pick it up. It will detect it. It won't interfere with a patient's sleep, but it will detect it. And three, it has a couple handy things. One is it shows the trend. So it shows over 90 days what the heart rate trend is. If there are episodes of AFib or aflutter, it shows how often they occur and how long they occur. And thirdly, it calculates AFib burden, which means what's the AFib burden per month? Of course, we like to see it 0. But if it's 2%, do you really need to do something about that? That means 98% of the time the heart's in rhythm. Maybe not, but it helps us decide because it's very objective, 24-hour based.
Okay.
Kind of a long answer for your question.
Does having a history of preatrial contractions or ventricular attraction, PACs or PVCs, predispose you to developing AFib?
First of all, I don't know the answer to that question. Premature atrial contractions, so those are extra beats in the upper chambers. Premature ventricular contractions, extra beats in the lower chambers, are quite common. And we're finding out that they're more common than we thought now that we have these implantable monitors. We consider them generally benign. We don't treat them. Sometimes the lower chamber extra beats, or PVCs, are so frequent that a catheter ablation is recommended to try to decrease the frequency because there may be symptoms. But as far as whether they predispose to AFib, aflutter, I don't have the answer. We certainly see them both in patients that we put the device in to see if they have AFib, and in patients who've had the procedure, we still see them, but I don't know the correlation between that and AFib.
Okay, fair. What are the parameters for your weight and BMI to have the procedure?
Okay, that's an important question. So BMI is body mass index, and it indexes a person's weight to their height. And it's normal to have a BMI of about, I think it's 27 or 28. I think 27 is normal, 20 to 27. If the BMI is greater than 35, it increases the complexity of the procedure dramatically. So from a technical standpoint, it makes it much more difficult. It's difficult. All the instruments are made one size, and I designed a lot of these instruments, and we didn't make them in different sizes. They only come in one size. So if a patient is quite large, then the distance between the skin and the ribs and the chest wall increases, and it's hard to get those instruments in the right configuration. It can be done, but at some point the risk is great and the benefit starts to go down. So initially I was doing everybody, but it became abundantly clear that the technical hurdles became pretty great with morbid obesity. And probably the best things that has happened in the last several years are the newer drugs to lose weight. And we have had many patients lose over 80 pounds before they came for their procedure. It's an advantage for the operator, me, because I don't have to go to the ICU after the procedure, and it's not as difficult. It's a big advantage for the patients because they routinely tell me they feel so much better just by losing that weight. Even though they may still have AFib, they can still get around a lot better before the procedure, which means they can get around well after the procedure. So for mobilization issues, it makes a big difference. What's the cutoff? We ask people to try to get down to a BMI of 31. Now we make some exceptions, but I think that's important, not just so a patient can get through the procedure easier, but it makes everything better. It really improves the recovery. So we try to get down to a BMI of 31, which is a much more attainable goal now than it was 10 years ago because of the newer drugs on the market. Initially were put on the market for diabetes, but they really are effective for losing weight. And I think it's great.
Good. Have you ever not been able to clamp the appendage due to a size issue or any other reason, and then you would just remove it, correct?
Okay. We routinely close the left atrial appendage. The first 1,000 cases I did with a stapler that had titanium staples on it. It was used to close lung tissue, but it works very well for the appendage. And we were always able to close the appendage. The last probably 2,000 since then, for the most part, I've used a clip. And the clip is a little bit easier, a little bit safer, a little bit faster, so I tend to prefer the clip. But no matter how big the appendage is, the base of it is usually not larger than 5 centimeters. So if you think of a hot air balloon, it has a lot of air in it, it's very big, but the base of it is not that big. Appendages tend to do the same thing. They may get quite large, but the base of the appendage is still usually reasonable. So we've been able to close appendages in almost every situation because the base isn't that big. I'm thinking back now off the top of my head, I can't think of any that we couldn't close. So even if it's large, it's not a uniform large. The base is still usually 3 centimeters to 5 centimeters, and our clips are 35 millimeters, 40 millimeters, 45 millimeters, and 50 millimeters, which are 3.5 centimeters, 4 centimeters, and 5 centimeters, and 4.5 centimeters. And that covers everybody pretty darn well.
I was one of the first ones to get the clip.
What's that?
I was one of the first ones to get the clip. Our whole group, that our six people that came to you, I was the last one.
Yeah.
And they all had theirs removed in a little jar, and I didn't. I had the clip.
That's right. Yeah, that's right, because with the stapler, it cut the appendage off, and then I would show it to the patient. You didn't have that opportunity, did you? We can go back and do it.
Okay, please.
Now, a related question that comes up frequently, I don't know with you, but with me it certainly does, is people want to know if they can have an MRI with the clip in.
I get that all the time.
Do you? Yeah.
All the time.
And the answer is yes. And the reason is this. You can't have iron and get in the MRI machine. There is no iron in the clip. The clip is made of titanium.
Titanium.
Titanium is fine for MRI. In fact, same with the Link, the implantable monitoring device. It's titanium. There is no iron in it. So it doesn't go off when you go through the airport, and it doesn't interfere with a MRI.
What eventually happens to the appendage once it's clamped?
Yeah, well, the original study, and this was sponsored by AtriCure, who makes a lot of the equipment that I use, a lot of the devices, was done in baboons. And the clip was, the clip was put on, and then the appendage was assessed 6 weeks later. And the appendage involutes. It turns in just to a little nub. So it shrivels up into a little nub and it looks like just a little bit of a scar just outside the clip. And that's what happens in humans too. So the good news is it's no longer electrically active, as opposed to a Watchman where the appendage is still active and full. But with the clip, the appendage just involutes down to a little nub, and it's not electrically active.
Okay. Are the ganglionic plexi nerves different for men and women, and can they grow back?
Okay. To my knowledge, everybody's wired a little differently. I don't think it's based on your X and Y chromosomes, but everybody's wired just a little bit differently. For example, I do the same line, and some people, their heart rate goes down a lot, and some people it goes up a little bit. So it's quite variable. I don't know of any differences in the wiring of the men and women with respect to the ganglionic plexi. Can they grow back? Potentially the neural tube can grow back. However, it won't work because the axon, the main body, no longer is alive. So even if the tube grows back, it will not be functional.
You kind of answered this one about does everyone need a link and the pros and cons, so I don't know that we have to go through that anymore. But somebody wanted to know, she's 80 miles from Houston. She wanted to know if she could drive herself home when she was released from the hospital.
The official answer is no.
Yeah.
And I guess I better leave it like that. Well, I can say this, have people driven home after having this procedure? The answer is yes. Not recommended, but it's certainly been done.
I suggest that you stay at least for a couple days.
Yeah. But there are no driving restrictions once people get home. Usually you can drive, you can walk, you can increase your activity as you see fit, and we have not restricted driving.
Once I got home, I was fatigued for quite a while, tired. I napped, which is something I never do, but I went back to my normal routine almost immediately. I went back to 12-hour nursing shifts at 5 weeks. Probably shouldn't have done that, but I did. And went to Europe at 10 weeks for 3 weeks and never knew I had anything done.
Everybody's different. You're a quick healer. We've had
not necessarily.
No.
I could not have, like these people that jump off the OR table and go to all the museums in Houston. There's no way I could have done that. No way.
That's a good point. I'm not recommending this, but some patients have taken me out to dinner before they left Houston. Had their surgery on a Monday and took me out to dinner on Thursday, which is pretty amazing. But not everybody's like that. Everybody's a little bit different, and people respond to trauma in different ways, right?
Exactly.
Yeah.
Exactly.
Go
ahead.
No, go ahead.
Okay. Would it be unreasonable to think that I could have the Wolf procedure after only having had a few months of AFib?
That would be unusual. And what I have been recommending in those situations, Sandy, is to consider putting the link device in. Because we did a study a long time ago. Gosh, it's almost 18 years ago. And we had people wear a monitor. This was before the link. And they also kept a diary. And they wrote down whenever they thought they were out of rhythm. And then we matched that to what the monitor showed. It was a 48-hour Holter monitor. And patients were right only about 50% of the time. Now, some patients were spot on. They knew the beat they went out of rhythm and the beat they went back into rhythm. Other people had no clue. And they say, okay, I think I'm out of rhythm now. And they were in rhythm. And then they were out of rhythm and they thought they were in rhythm. So the advantage of the implantable monitor is now we have the ability to put one of these in for a couple of months and truly objectively assess what the AFib burden is, apart from what the patient says. And sometimes we've been surprised. They had a lot more AFib than they thought they did, particularly nocturnal or AFib at night. And in patients who didn't know they had much AFib at all. So I have been recommending the placement of the monitor, objectively find out how much AFib a person is having, and then talk it over and say, is this enough that you want to do something about it?
Okay. I've had multiple people ask me if they should have the Wolf procedure or just have an AV node ablation, a pacemaker.
Oh my goodness. Well, let's backtrack just 1 minute and point out that in many cardiology practices for many years, it has been if someone has AFib and you can't control the rate, do an AV node ablation and a pacemaker, which means your God-given pacemaker is wiped out and you're totally dependent on an electronic pacemaker. You still have AFib. It does not treat the AFib, as you well know. It doesn't stop the AFib, but it stops the fast heart rate. About 25% of people who have pacemakers go into heart failure. So it's not a benign process. Fast forward to where we're doing catheter ablations, and the end recommendation has been the same. If you have AFib, it's not well controlled, and the catheter ablation doesn't control it, well, then get an AV node ablation and a pacemaker. And I think that's a really bad way to go. And you figured that out yourself when you were faced with that dilemma. And I've even done the Wolf procedure on people that had AV node ablation and pacemaker, and we have been able to get them back in rhythm, which proves that there's a better way to go. So I don't recommend it. I think it's much better to try this other option, a minimally invasive surgical procedure, before going down the road of AV node ablation and pacemaker.
I've also had multiple people ask me if they had the Wolf procedure, would they then be able to not use their CPAP machine anymore? And how much do you think sleep apnea contributes to AFib?
There have been several articles published that show a relation between untreated sleep apnea and AFib, and documenting that when the sleep apnea is properly treated, the AFib burden decreases. And there's even one ganglionic plexus that's called the sleep apnea GP. It's on the right side and it's medial, it's on the other side of the superior vena cava, and I routinely burn that area. But I don't have any study to show yet that it makes a difference. So I don't know the answer. I suspect it does, and I suspect if you stay in rhythm, you're more likely to stay in rhythm if your sleep apnea is treated, but I'm not sure that getting back in rhythm makes the sleep apnea better. It might, just because your hemodynamics are better when you're in rhythm and you're less short of breath when you're in rhythm. but it's a complex relationship. I'm not sure.
So they need to do to keep up with the CPAP after the procedure. Correct?
Yes, in fact, it's important to use the CPAP in the hospital during the day after the procedure because it opens up the lungs after surgery. It's extremely beneficial. So for anyone coming to Houston, bring your CPAP machine with you, not just for nights in the hotel, but in the hospital post-op during the day. If someone's watching TV or reading a book, put the CPAP mask on. It'll help. And that reminds me, I didn't give the number out at all for if someone wants to talk to Kimberly, but it's 713-441-9342, or go to the website, Wolf Procedure website, but 713-441-9342, or go to the website if you're interested in getting an appointment. Mr. Producer, did we have any questions that we need to get to that I didn't yet? Let's see. What would be an example of how AFib can return after the blanking period? Okay, the blanking period was a term coined by electrophysiologists, and it generally refers to the first 90 days where the heart may have some inflammation from the procedure, may go in and out of rhythm, and they believe that after 90 days things have settled down. So what I try to do is have people on a small dose of amiodarone before the surgery that protects them immediately after the surgery and more likely will keep the heart in rhythm. So usually what we see is they stay on the amiodarone for about 90 days, then we start to wean the amiodarone, and maybe after weaning the amiodarone they go into fib or flutter. Usually it's flutter. If we see that, we do a cardioversion, we restart the medicine, wait a little bit longer. If they fail a second cardioversion, then I have them call Dr. Fahed and look into a catheter ablation follow-up. My Lifeline screening a year ago indicated mild calcification on my carotid artery ultrasound. Will the pre-op for the Wolf Mini-Maze screen for this too? No. The scan that we do is essentially here at Methodist is from here to here. So it's for the heart. It's very good at showing the coronary arteries, and it's very accurate in diagnosing significant blockage in the coronaries, but the carotids are outside the field. Is the procedure open? No, it's not open. It's not through a sternotomy. Why does heart rate increase significantly during recovery? How long before it's expected to decrease? Well, as I mentioned earlier in the program, for some people it increases, some people it decreases. And they have heart rate in the 50s and it stays in the 50s. Other people it is higher. It tends to come down. It can take a year, but it tends to come back down towards normal. Were you in that group?
I did. I actually ran in the 90s for almost a year. And then it slowly came back to normal. Well, 90s and into 80s hung out there, but it slowly came back to normal. Now I'm 60, 64, 66.
Okay, well, that's a good answer for that. I want to try to finish up with any other burning questions that you might have, Sandy. How are you doing?
I only had one other one. I've had a couple of people ask me this. If they're taking flecainide now, are you going to take them off of flecainide and put them on amiodarone?
Yeah, that's a good question. Amiodarone is shown to be far superior before the procedure and immediately after the procedure, not just for the Wolf procedure, for any heart surgery. And I just looked at a protocol earlier today of prophylactic, that means before, prophylactic use of amiodarone before heart surgery. And we're going to that here at Methodist Hospital routinely. So for any heart surgery, it tends to settle the heart down. But the key for me is to give it in low dose and start at least a month before the procedure, if possible. Then it works quite well. The key is low dose. Flecainide doesn't do as well with surgery, not anywhere close to the protective effect at least with AFib, of amiodarone. But if someone's doing really well on flecainide, I'm okay with that. But they're probably going to do a lot better on amio. So usually a month or two before the procedure, I prefer they switch if they can. Not a hard rule, but we try to. Now, any recommendations for people who might be visiting the Facebook site? I mentioned the news that the wait list now is down to 30 days or less for people who qualify for the procedure. Maybe we should put that on the Facebook site too. Probably be helpful. Anything else that's you need to get off your shoulders?
Nope. Lots of people joining all the time.
Yeah, and I guess I'll end with one comment. I think the Facebook site's incredibly important and helpful. It's not always the full cross-section of people. There are a lot of people that have this procedure. They do extremely well. They don't even consider themselves to have AFib anymore, and they may not get on the Facebook site. But there are some people.
I think everybody's really supportive. And
Yeah.
I think that's the issue. They'll answer questions and they'll get 5 different answers because everybody's recovery is different. But I think that the main thing with the group is a lot of people have told me they've learned more from the group than they did their own EPs because the group talks about things.
Well, the bar's kind of low too. I'm just kidding. But no, I think that's true. That's true. We have to remember, though, there's a lot of information on the internet. But it's information. If you want knowledge, then you've got to sift through that yourself. You've been very, very helpful in guiding patients in the right direction.
Well, I think what's good too is that, everybody talks about their experiences and they're not all good.
Right.
I mean, some people have issues. So,
That's right.
I mean, people like to know about the issues that could come up as well.
Yep, that's right. That's right. Well, in closing, I want to thank you 1,000 times for all the work you've done. You've helped so many people. I think you've helped more people in your retirement, and I say that with quotation marks because I think it's a full-time job for you, than you did when you were employed in a hospital. And a lot of people, the people tell me who come here over and over again, thank God for Sandy getting me on the right track and helping me out. So on behalf of all the people that pass that on to me, thank you so much for all that you do.
You're welcome.
And I think we'll be live again in a month, the first Tuesday. And we'll continue this same plan that we initiated, that if you're viewing this after the fact and you have a question, you'll be able to submit it and we'll review it on the next webcast. Everybody have a good rest of the day and a wonderful autumn. And Sandy, thank you so much.